Welcome to Vein and Lymphatic University Grand Rounds. My name is Lowell Kabnick, and it's a pleasure to have you join here with us. Today, we're going to be talking about Chiva strategy, and our lead speaker is Erica Mendoza, and then our discussants will be Sophie Zhu, and as well as our guru in Chiva and founder, Claude Franceschi. I turn the floor over to you, Erica, and please share your screen.
Thank you so much, Lowell and Victor, for doing all these wonderful things. I try to share my desktop, and here I am. So I want to introduce you to Chiva in 10 minutes. This is the plan, and I will start my clock. Chiva is the strategy to correct the failure of the leg veins to defend against gravitation. And Claude, who is here, which is a great honor, developed it and presented it back in the 1988. And he's a brilliant thinker and gave this theory to us, giving lots of lessons. So I could learn this very interesting option to treat veins. Now why can't I? Yes. Chiva is all about hemodynamic assessment. And this was a problem when 35 years ago, when Claude presented this, he was a pioneer of Duplex. And it was difficult to be understood by people, especially the opinion leaders of the time, that had no idea of how to apply Duplex. And now, 35 years later, if you do not understand Duplex, you should not be performing phlebology. I'm very sharp in this, but I'm very convinced of this. Or you should involve your technicians in the decision taking, because in some structures it is really the technician who is very, very good doing Duplex, but it should be part of the team and not writing something down and somebody else decides without any discussion. Chiva is really as easy as finding out the feeding source of the reflux. I will talk about GSV because it's the most often. The reflux source of the reflux in the saphenous vein and the draining course. And the reflux source can be a deep vein, and it can be a deep vein through terminal valve reflux or a perforating vein. And it can be a tributary feeding the great saphenous vein itself by pelvic or perforating reflux. And the drainage can be either perforating vein or a tributary where the reflux just exits the great saphenous vein. I just have to come back to one very important point, technique versus tactical approach. There are techniques to act on veins and tactical approaches. We have two tactical possibilities. If great or small saphenous veins are refluxive, we can destroy them with whatever, surgically, endominally, chemically, physically. And if they are refluxive, we can restore them. And we can do this also with a lot of techniques. But the tactic Chiva price is to restore the function of the great saphenous and small saphenous veins. Let us just dive in a case. This is Chiva with a recirculation from the deep vein through the saphenous vein with the perforating vein and the secondary tributary. You do a crossotomy, I will come back to this later, and a flush ligation of the tributary. So you interrupt both recirculations. And afterwards, you have, closed here, you have feeding tributaries that will drain retrogradely. And this was what House misinterpreted in his study, and drained physiologically to the deep vein. And the tributary will reduce the caliber. So we see this here. In this case, we did only a crossotomy. The guy had a burn from 3 or 4 years ago in the ankle. This is not venous insufficiency. It is round. But he had a large varicose vein and he was afraid to have any kind of intervention. So he wanted to just have a minimal thing. We did a crossotomy as the first step. And 3 months later, the leg looked like this. No edema, no more edema. And the restoring of the function of the GSV was good. And the tributaries didn't bother him. He was happy. So what did we do especially in the crossotomy? This is a cetus in the groin. You see the great saphenous vein. This is the scheme. This is the great saphenous vein. You see the ostium, the wall of the femoral vein, and this is where the thread is gone underneath all the tributaries of the groin underneath them and closing at the very level of the terminal valve to allow the competent um, veins of the venous star, as we say in Germany, to drain into the great saphenous vein and avoid a thrombosis of the great saphenous vein. Just a short excursion. If you do high ligation or crossotomy, please use non-absorbable material because, as you see here, I compared long time publications of 5 to 10 years follow-up, and I was very surprised about the great diversity of neovasculogenesis in all the publications. And so I found that those using, why does the mouse not work here? Those using non-resorbable or titanium clips had far less revascularization than all those using resorbable ones. So this is not a prospective randomized, but if you do crossectomy or if you do crossotomy, just please use non-resorbable. This is a case of a long-lasting reflux from the groin to the ankle in the saphenous vein, which is not so often, but it happens. And the patient has, for example, an ulcus here, and there is a large perforating vein. So you can close the reflux source, and to interrupt the pressure from the groin to the ankle, you may find a good draining perforating vein like here, and then this is the point of the perforating vein, then go here and interrupt the saphenous vein, which you see it is like a little bit of like a pearl below the perforating vein. So you oblige the blood of the tributaries to drain to the deep vein, and you have lesser pressure on the ankle, favoring the healing of the ulcer. So it is all finding the reflux sources, the draining pathways, and reducing the pressure column. This one is a very, very important thing. 25% of patients that come to your office wishing a surgery, this was studied in above 2,000 legs in Germany, not those coming to investigation, but those scheduled for surgery, have a reflux only in the pre-terminal valve with a competent terminal valve. And if you do the following, you just interrupt the tributary, flush ligation, I will show you. You have in 97% of cases a complete restoring of the complete flow in the great saphenous vein. How do we do this? We have to do a little larger incision to be sure to see the great saphenous vein, the tributary, and to make a real flush ligation. This was the case of this lady. Normally, you have not so large varicose veins when the terminal valve is competent. And we did what we have shown. We did the interruption of the tributary 2 months, 3 months later, 4 months later, September to January. You see that the tributary, we did nothing else than just doing this. The tributary has disappeared and the great saphenous vein was anterograde. Some people say Chiva is only to be used in easy cases. You can't do it in complicated cases. So I show you a case with T3. You have edema, you have itching, and he came only because he was affected by the itching. He had a real large great saphenous vein diameter, proximal thigh 1 centimeter, which means 70 millimeters in the groin region, and a large reflux in proximal thigh. And we did, in this case, a laser ablation, a short laser ablation. I know Claude is not so fond of it, but I had to react according to the possibilities I have. I had 7 centimeters GSV ablation, and he was with atrial fibrillation, so he could take his medication without changing anything. And I closed in local anesthesia proximal 7 centimeters, and this is 9 months later. The proximal GSV has reduced caliber. There is a normal flow in the proximal GSV, and this is pre and post. And if I think people say, yes, and what did people argue? They have to wait, and so on. But if you see this result, and they had to have phlebectomies all around, I think it is a good option. This last case is a patient he had atrial fibrillation, also had large varicose veins, and we did a tilt test filling with a very large working volume and a near waterful like filling of the leg and emptying. The deep veins were perfect, and filling again, And we did a short Chiva, as I said, a short proximal ablation, just that to show the effect of just one interruption to reduce the volume in the leg. And this is only 2 months later, you see the coloring of the leg had changed. The volume is next to half of it, and the refilling curve came back to normal. After treatment is compression stockings for 4 to 6 weeks to support the reduction of the diameter, anticoagulation, if the patient needs, depending on the clinical situation of the patient. If the patient is anticoagulated, you don't have to discontinue it, and expect vein disappearance in 3 to 6 months. And the caliber reduction has been demonstrated after 5 years in my office. The diameters of the great saphenous vein proximal thigh were very large, 16 millimeters, and they went down. Sorry, this is the deep femoral, the common femoral vein, but the diameters went down significantly, and also after 5 years. Every person willing to learn and able to perform duplex ultrasound of leg veins is able to learn and perform Chiva. Patients will thank you, as they will have no reconvalescence. They can go back to work. They can do everything next day. You should be trained and be able to offer more than just one option to the patient. And I think, like we learned in every part of medicine, where breast amputation for tumors is reduced to tumor excisories and so on, risking recurrences, why not in venous treatment? Primum non nocere is something we all have in our Hippocratic oath. I thank you so much. I hope I stayed in my time, and I'm open and happy to discuss with you whatever you want. Thank you.
Thank you, Erica. That was brilliant. Of course, I have lots of questions that are coming, but I want to turn it over to Sophie, and we'll follow by Claude. Sophie, your
Hello.
discussion and/or questions.
I have no questions until now because I would like to have some comment. I'm Sophie from Shanghai. I'm based in Shanghai. So I perform Shiva surgery since 2017. And now every year I have almost 300 vascular surgery, how to say, the varicose vein surgeries, and almost all of the surgeries are Shiva surgery. So I would like to say the patient are really welcoming the Shiva surgery. And before they come to consult me, maybe they get news, they need to get the stripping or radio frequency or stereotherapy, something. So they are scaring of all this surgery. Then when I tell them we have another choice of Shiva, they are very willing to accept the Shiva. So I think is a very good option for the patient, especially for the patient, especially the patient don't want to destroy their veins. So now I'm practicing Shiva nearly every day. So really support this surgery.
Well, thank you very much. So before I turn it over to Claude, I've got to ask both of you, when wouldn't you do Chiva? Erica?
I wouldn't do Chiva if the vein is too small. If you have a vein refluxing with a caliber of less than 2 millimeters or 2 millimeters, which sometimes happens, you have to think that if you do Chiva, the vein valves that are not meeting because the vein is enlarged, if the volume is reduced, they will meet again. But if you don't have meeting valves with 2 millimeters of diameter, you can't expect an amelioration with closing reflux sources. This is one point. And the other point is if you have a post-thrombotic changed vein, you can work chivoid. I mean, you can do a crossectomy, for example, and then to avoid recurrences, I foam the vein because it's already altered, and you can't expect it to recover completely like it does if there were no previous thrombosis in the vein. And there are no other situations. The larger the vein, it is, you can treat Chiva to every reflux if you find the source, and you find it if you look.
The next question to you would be, if you have outflow obstruction, iliac outflow obstruction, which occurs in about 30% of C6 patients. Do you do Chiva before you relieve the outflow obstruction? Is that a
Yes.
problem?
Yes, it is no problem because with Chiva you can do, for example, most of the patients, for example, women after pregnancy, they have a iliac vein closed in the left leg, in the left side, and they have a connection to the right side, and then you can close if the great saphenous vein is refluxing. You have to study, of course, if there is also a superficial reflux, because if the superficial dilated vein is the one draining the leg, you can't touch it. But if you have the superficial vein refluxing down to the ankle and you close it selectively below the outflow of the below the junction, below the connection between the deep vein and the pudendal vein, you can just close the great saphenous vein below. Or very often it is the mid-thigh perforator that fills the great saphenous vein upstairs and downstairs, and you can close the vein just below the perforating vein. So you can very punctually reduce the reflux to the leg and allow the drainage, which is, I mean, this is not the concept you apply when you do stripping, because you would extract everything. But you
Claude?
can do Chiva in
Claude?
this cases very well.
Yeah. Claude, what do you think?
Is that me? Oh, well, I don't think. I just try to understand. And I went to Shiva just because as a vascular, too many times we had problems with patients where we needed to perform a bypass for the arteries. And they had no more saphenous vein because of stripping or whatever sclerosing. So I tried to find a way to treat the varicose vein without destroying the saphenous vein. And I tried to understand what was the current knowledge about physiopathology of the venous insufficiency, particularly superficial. I didn't understand it because there was nothing to understand. There is nothing. It was a desert in terms of physics and hemodynamics. So using the Doppler, it was easy for me to understand and to find the better model possible of the venous function and the venous dysfunction, and how to treat it. Just treating what are the causes of excessive intravenous pressure. And the cause is the height of the column of blood and the presence of closed shunts, of venous shunts. And so the solution was disconnect the shunts without destroying the vein in order to have to reduce the excessive flow to the normal flow and excessive pressure to normal pressure, and to obtain what? A good drainage, because the function of the veins is drainage. It's not nothing else. It's drainage. And to have a good drainage, you have no venous problem, no skin problems no more, and no whatever, ulcer, whatever. This is one thing. The second thing is it's terrible because people say Shiva is difficult. Yes, for me, everything I don't study is difficult. But when you study, then it's easy. But people, phlebologists, and even teachers and professors don't teach hemodynamics. That's funny, like your plumber doesn't know how the water flows in the tubes, That's terrible. And so we have, and I try since so many years to make people to understand. And this pathophysiology with hemodynamics makes possible Shiva, deep Shiva, in the deep veins, in the post-thrombotic syndrome and so on. Very easy. At the moment you understand something, it's easy. Two ways to is easy. One easy to be ignorant. You don't know and you do what they told you to do. And the second one is to understand. You don't do what they tell you to do, but what you understand, it's better for you, for the patient. So it's a real challenge to explain Shiva in 10 minutes because you have to explain the pathophysiology, the basics. People doesn't know. That's terrible. What's such an ignorance when
Claude,
it's
I
possible
have
to
a
have?
question for you. Can you explain, by example, a deep Shiva case?
Yeah. For that,
2 minutes, very
yes,
quickly.
it's very easy. You have, I have made a video. You go videos to Claude Franceschi and on YouTube, and you find a video that explains diagnosis
How
and
about
treatment.
here? Can you tell us now when
Yes,
you would use it?
in 1 or 2 seconds, when you
Yes.
prefer. 2 seconds or three. Yes, I try. You know, for example, in this video, there is a patient who has a closed shunt made by the deep and the superficial femoral vein. And we disconnected this shunt with a patient who had an ulcer, resistant ulcer. And he was treated, and we transformed an incompetent venous pathway to a competent one, just disconnecting the deep shunt. The other one has had a shunt between two posterior tibial veins. One was incompetent, the other one was competent. And this created a shunt, a closed shunt. I disconnect the shunt and well, it's everything. It's easy. But the problem is I have not to show you cases, but I think if
I
somebody,
appreciate that, Claude.
no, I mean,
It's
if somebody understand anatomics, addition, arithmetics, addition. You have not to explain it that 1 + 1 is 2, 3 + 3 is 3. At the moment he understands, you don't have to give him number, but just how
Claude.
to count.
Not lower,
Thank you very much. Erica, I've got some questions that are on the board here, and some of them are poignant. The first one that I think is really good is from Michael Elab, and he's talking about the guidelines. In the American guidelines and the European guidelines, where does Chiva fit in?
the problem with the guidelines is that they are run by the opinion
Uh,
leaders of the
I
professors.
didn't
No,
ask
and
that
in the
question.
German guideline, Chiva is already where it deserves, because I was part of the guideline. And if people writing guidelines is not able to understand it, they can't include it. So there is no European or American guideline referring to Chiva. But this
Erica,
is the this is
we read the literature and we understand it and we look at what's going on. Now there are some really good papers on Chiva. You're right about the people that make up the guidelines, but they're pretty open people. And so if you look at the number of Chiva cases that are performed throughout the world versus the other cases, it's in a minority. But
yes, but it depends on the country. In Spain, it is
very
more than
quickly, very
in Spain for
quickly,
yes. In Spain, it is more than 50% done by Chiva. In China, it is improving very much. It depends if the doctor is reimbursed by procedure or if the doctor has a salary and can do what he wishes. This is a very
well,
important
I'm
differentiation. Sorry.
I'm
And
sorry
if
that you think that way. I hopefully people react according to what's important in the guidelines. So that being said, Professor Boskirk wants to know originally that Chiva was it developed to for saphenous sparing? And I think
uh,
Claude, you mentioned that it was
yes,
originally for saphenous sparing. So moving on, then there was a question by Professor Boskirk about how long does it take to do a good Chiva?
I
Yeah.
started 27 years ago, and it took me an hour to understand the leg because I was young and I hadn't experience. Now it takes me, depending on the case, between 10 and 15 minutes to understand the leg, to make the plan. And the intervention depends. If you have a crossotomy, it will take you 10 minutes. If you have a crossotomy plus tributary interruption, it depends on the touches you will have. If I do it with Chiva hot, it takes me 10 minutes because it's just a short segment. I have to anesthetize and I have to close. So it depends. If you are used to do it, the procedure is short because you do much less than if you do phlebectomies and so on. The problem is analyzing the patient and finding out which touches will be the most important for this patient. This is the most long time investment you will have in explaining the patient, we can do this, we can do this, depending if you accept to perhaps having a second touch. And this takes, like, if you are experienced, takes 50 minutes, 30 minutes. And you have to count this to the procedure because the procedure is the plan. A donkey can do the operation, but the plan of the operation, this is the procedure itself.
Can you talk about quickly recurrence rates?
Yes, there are also some studies, and the recurrence rate in direct comparison between Chiva and stripping were half of it in 2 studies. And in one study from Spain, it was at the beginning it was the same, and then the scissors opened, and it was Chiva like a third less than stripping. Yes, Claude.
Claude, Sophie, your comments on that recurrence rate?
Voilà, je cache là si tu veux.
Claude?
Yes, Claude?
Sophie et Eric.
Yes. Chiva has less recurrence rates, and the difference, which was analyzed by the Spanish group, was that these lots of little vessels you have around the stripped vein, they don't occur if you leave the vein in situ. You know, these spider veins appearing at the inner part of the leg, for example, doing reticular veins, these ones are not observed after Chiva. And they accounted for 18% in this randomized prospective study, 5 years. And at the groin, by the same surgeon, you had the same number. They had three recurrences on 75 in the groin, and they had a reopening of a perforator in the same number of cases. But the difference were this very bothering number of reticular veins if you destroy the vein.
The last
Final comment, Claude. 1 minute.
My comment is now we have a study 20 years. A study Chiva versus stripping in
Anybody do stripping anymore?
In open, yes, in open blinded study. We have 20 years. But if people doesn't want to understand, they say it doesn't exist. All the studies, versus Chiva, whatever the world, show that Chiva give at least equal or less recurrence than the others. 1. 2, it keeps alive the great saphenous vein as a bypass, because it happens much more than said that
Claude,
it is necessary for the patient.
Claude, I've got 1 minute left.
I'm sorry,
Sophie,
but
you got
as
a
a doctor,
comment?
as I was
Claude?
doctor,
Yeah, I have some
patients.
comment.
Claude, thank you. Appreciate it. I got 1 minute. Go ahead.
Yeah, thank you. I think Shiva is a strategy, is not only a procedure. So I just put in the chat box. So for some cases are very complex. For example, the patient has the iliac vein stenosis, or they have the history of deep venous system problem. Shiva still works. So it can help the doctor to understand more about the hemodynamic and what happened on the patient. So it can solve the patient problem. So go back to the previous question, like the patient have
20
the
seconds.
yeah, have the varicose veins and the iliac vein problem, we still can do the Shiva, but according to the hemodynamic, it's just a concept. But I hope we can have more time and in the future we have this
Thank you
session.
very much. The time is short
Yeah,
now.
I
Next
know.
week, we are going to talk
Thank
about
you.
deep valves, where we are now. And I'm going to then probably have another Chiva meeting. So be aware that it will occur. And thank you very much for everybody
Looking
attending.
forward to that.
Have a
Thank you.
good day.
Thank you very
Thank
much.
you.
Thank you, Lowell.
Thank you,
you.
Claude. Thank you, Sophie. Thank you, Erica.
Thank
Bye
you.
bye.